What doctors really think of older people is not something most professionals say out loud, not because they are cruel, but because the truth can be uncomfortable. Today, we're going to talk honestly, not to scare you, not to shame you, but to empower you. Because once you know the reality, you can change how you show up, how you're treated, and how seriously your health is taken. The first truth is this: doctors quickly judge how serious you are about your own health. If you repeatedly ignore advice, skip medication, refuse basic lifestyle changes, or laugh off symptoms, many doctors quietly lower their expectations. They may still treat you, but internally they assume you won't follow through. That affects how aggressively they investigate problems and how much time they invest explaining options. When a patient shows discipline and responsibility, doctors lean in more. When a patient shows resistance and denial, doctors often step back. The second truth is that some doctors assume certain complaints are just aging. Fatigue, pain, memory lapses, poor sleep. These sometimes get mentally labeled as normal decline instead of warning signs. This doesn't happen because of evil intent. It happens because patterns shape thinking. But it means seniors who don't clearly describe changes, timelines, and severity risk being brushed aside. Precise communication earns precise care. Vague complaints often receive vague solutions. The third truth is that attitude changes the quality of care more than most seniors realize. Respectful, cooperative, prepared patients get more engagement. Angry, dismissive, or constantly argumentative patients, even when they're right, often receive more mechanical care. Doctors are human. Emotional friction reduces collaboration. Calm persistence, written questions, and organized records often get better results than emotional confrontation. The fourth truth is that doctors worry more about lifestyle than prescriptions, but they know many older patients won't change. Movement, diet, sleep, alcohol, smoking, stress, these matter more than pills in many cases. Yet doctors see decades of habits and assume change is unlikely. When a senior proves them wrong, starts walking, improves nutrition, tracks numbers, it stands out. Effort gets attention. Action gets respect. The fifth truth is that independence is the strongest positive signal a senior can send. Doctors are deeply concerned about fall risk, medication confusion, and isolation. When they see someone mentally sharp, physically active, socially connected, and managing daily life, they automatically think higher recovery potential. When they see total dependence with no support plan, they become cautious and conservative in treatment decisions. Now here's the empowering part. None of these truths are fixed labels. They are impressions, and impressions can be changed. Show preparation, track your symptoms, follow through, ask focused questions, take ownership, demonstrate effort. When you do, the tone of medical care changes. Conversations become deeper, options become wider, respect becomes mutual. Aging does not reduce your worth, but engagement increases your influence. The more active you are in your care, the more seriously you are treated, and that is a truth every senior deserves to know. Doctors often form an early impression of how seriously an older patient takes their own health, and that impression quietly shapes the way the appointment unfolds. It doesn't usually happen out loud, and it's rarely intentional, but it is very real. Within the first few minutes, a physician is noticing patterns, whether medications are being taken correctly, whether prior advice was followed, whether test results were ignored, and whether the patient shows ownership or avoidance. When a senior repeatedly says, "I forgot," "I didn't think it mattered," or "I never started that," a silent conclusion can form. This patient is unlikely to follow through. Once that assumption settles in, the doctor may simplify recommendations, avoid more complex treatment plans, or reduce the time spent explaining deeper options. On the other hand, when an older patient arrives prepared, with written questions, updated medication lists, tracked blood pressure or sugar readings, and clear symptom timelines, the dynamic changes immediately. The doctor recognizes engagement and responsibility. That often leads to more detailed conversations, more diagnostic curiosity, and more personalized treatment strategies. Preparation signals partnership. It tells the physician that their effort will not be wasted. Consistency matters even more than perfection. A patient who admits difficulty but shows effort earns more respect than one who pretends everything is fine while ignoring guidance. For example, saying, "I walked 3 A's this week instead of 7, but I'm trying to build the habit," creates a very different reaction than dismissing exercise entirely. Doctors understand human limits. What they look for is intention and progress. Another factor is how patients respond to difficult recommendations. Lifestyle changes, therapy referrals, or medication adjustments are sometimes met with instant resistance.
When every suggestion is rejected, doctors may stop proposing broader solutions and stick only to essentials. But when a patient asks, "What's the smallest step I can start with?" the door stays open. That question shows willingness instead of defiance. Seriousness is also shown through follow-up behavior. Completing lab tests on time, reporting side effects accurately, and returning for scheduled reviews all send a strong message. My health matters to me. Physicians are more likely to escalate care, advocate for advanced treatments, and monitor closely when they see that level of commitment. The important truth is this: doctors respond to signals. Effort, preparation, and follow-through are powerful signals. They don't just improve your health outcomes, they improve how strongly your care team invests in you. Many symptoms in older adults get labeled as just aging far too quickly, and this can quietly delay diagnosis and treatment. In busy clinics, doctors see large numbers of senior patients every day, and patterns influence their first impressions. When an older person reports fatigue, joint pain, slower thinking, sleep trouble, or reduced appetite, it can be mentally grouped under normal aging instead of fully investigated. This doesn't always come from neglect. Often it comes from probability thinking, but probability is not certainty. Real disease can hide behind age-related assumptions. The risk grows when symptoms are described in a vague or casual way. Saying, "I'm just getting old," or "it's probably nothing," may sound humble, but it can unintentionally minimize the issue in the doctor's mind. Language matters. Specific detail changes clinical attention. For example, "I feel tired" is easy to dismiss, but "I've had crushing fatigue for 6 weeks, and now I get short of breath climbing 5 steps" is harder to overlook. Precision forces evaluation. Timing is another critical factor. Gradual decline is often attributed to aging, while sudden change is more likely to trigger testing. But many serious conditions, thyroid disorders, heart rhythm problems, depression, medication side effects, vitamin deficiencies, early neurological disease, can appear slowly. If seniors don't clearly state when a change began and how it progressed, it blends into the background of normal aging in a rushed assessment. There is also a hidden communication gap. Some older adults underreport symptoms because they fear being seen as complainers or worry about bad news. Ironically, this increases the chance of being dismissed. Doctors are trained to prioritize what sounds urgent. If discomfort is softened, joked about, or mentioned only at the end of the visit, it may not receive proper weight. Preparation helps break this pattern. Writing down symptom frequency, triggers, duration, and impact on daily life creates objective evidence. Bringing a short timeline, when it started, what worsened, what improved, gives the doctor a clearer clinical picture. Objective details push symptoms out of the just aging category and into that needs evaluation category. Second opinions are also a valid tool, not an act of disrespect. If something feels wrong and persists despite reassurance, another evaluation can catch what was missed. Good physicians understand this and often welcome it. Aging does change the body, but not every new problem is caused by age. When seniors communicate clearly and specifically, they greatly reduce the risk of their symptoms being explained away instead of properly examined.
Patient attitude strongly affects the quality of care more than most people realize, especially for older adults who may see doctors more frequently and for more complex issues. Medicine is a technical field, but medical care is still delivered by humans. Doctors respond not only to symptoms and lab results, but also to cooperation, communication style, and emotional tone. The way a patient shows up, mentally and behaviorally, can shape how deeply a physician engages in the visit. When a senior patient is respectful, calm, and open to discussion, the appointment tends to become more collaborative. The doctor is more likely to explain options in detail, explore alternatives, and spend extra time answering questions. This doesn't mean being passive or silent, it means being constructively engaged. Saying things like, "Help me understand this," or "What would you recommend if I were your family member?" invites partnership. It signals trust and shared purpose. In contrast, when every suggestion is immediately challenged, dismissed, or turned into an argument, the dynamic can narrow. Even good doctors can become more guarded and more mechanical when they feel they are in a constant fight, rather than a joint problem-solving process. The care may remain technically correct, but the depth of exploration and creativity in solutions may decrease. Emotional friction consumes the limited time available in most appointments. Preparation reduces tension. Patients who bring written questions, medication lists, and symptom notes tend to feel more confident and less defensive. That confidence leads to clearer conversations. Without preparation, visits can feel rushed and confusing, which sometimes turns into frustration directed at the doctor. Organization protects the relationship on both sides. Listening behavior also matters. Doctors notice whether instructions are heard fully or interrupted halfway. Letting a physician finish their explanation before responding often leads to better understanding and fewer misunderstandings. Then, thoughtful follow-up questions can clarify details without confrontation. Honesty plays a major role too. Admitting non-adherence, like not taking medication regularly or not following diet advice, is far more productive than pretending compliance. Accurate information leads to better adjustments. Doctors prefer truth over performance. None of this means seniors should tolerate disrespect or avoid advocating for themselves. Strong self-advocacy is important. The most effective form is calm, persistent, and evidence-based. Statements like, "This symptom is new and affecting my daily function. I'd like it investigated," are powerful without being hostile. The key idea is simple. Attitude shapes interaction, and interaction shapes care depth. A cooperative, prepared, and assertive but respectful patient often unlocks a higher level of medical attention and problem-solving. Lifestyle effort matters more than medication in far more cases than most older adults are told directly, and many doctors quietly believe this even when the prescription pad comes out. Medications are important and often necessary, but for chronic conditions common in later life, high blood pressure, type 2 diabetes, heart disease, joint problems, sleep issues, and even mild depression, daily habits frequently have equal or greater long-term impact. The difficult truth is that doctors know lifestyle change works, but they also know how rarely patients maintain it, especially after decades of routine. That expectation can shape how strongly they push or stop pushing behavior change. From a clinical perspective, movement, nutrition, sleep quality, hydration, and stress control influence multiple body systems at once. A pill usually targets one pathway. A habit targets many. Regular walking improves blood sugar, circulation, mood, balance, and brain function simultaneously. Better diet affects inflammation, cholesterol, weight, and energy levels together. Good sleep stabilizes hormones and cognition. No single medication can duplicate that broad effect. Physicians are trained on this, and they see it proven repeatedly in patients who commit to change. However, doctors also see the other side. Prescriptions get filled, but lifestyle advice gets postponed. When a patient repeatedly says, "I know I should, but I won't," some doctors gradually shift toward medication-only management because it's more realistic in that situation. Not better, just more likely to be followed. It's a practical adjustment, not an ideal one. What stands out strongly to clinicians is visible effort. When an older patient reports, "I started walking 15 minutes daily," or "I reduced salt and lost 4 kilos," it immediately changes the tone of the visit. Doctors often respond with more enthusiasm, more fine-tuning, and sometimes reduced medication doses when safe. Effort creates clinical flexibility. Lack of effort creates clinical dependence on drugs alone. Small changes count more than dramatic short attempts. Extreme diets and sudden intense exercise plans often fail quickly. Sustainable habits, modest activity, gradual food improvement, consistent routines impress doctors more because they predict lasting benefit. Consistency beats intensity in medical outcomes. Tracking also matters. Patients who bring step counts, weight logs, glucose records, or sleep notes provide usable data. Data proves effort and guides decisions. It turns advice into measurable progress. The empowering reality is this: lifestyle action gives seniors leverage. It can reduce medication needs, slow disease progression, and improve quality of life. Doctors know this well. When they see genuine habit change, they don't just notice. They invest more deeply in the patient's care plan because the foundation is finally strong enough to build on. Independence signals higher treatment priority more than most seniors realize, because in medical decision-making, functional ability strongly influences how doctors evaluate risk, benefit, and recovery potential. When physicians assess an older patient, they are not only diagnosing disease, they are also quietly measuring resilience. Can this person manage daily tasks? Do they move on their own? Do they understand instructions? Do they have social support? The answers shape how bold or cautious a treatment plan becomes. From a clinical perspective, independence predicts outcomes. Seniors who walk, manage medications, handle personal care, and stay socially connected tend to recover faster after illness, surgery, or hospitalization. Doctors know this from years of outcome data and bedside experience. When they see independence, they often think, this patient can tolerate stronger interventions, more advanced therapies, and more aggressive prevention strategies. When they see heavy dependence with no support structure, they may lean towards safer, more conservative approaches to avoid complications. Mobility is one of the strongest signals. A senior who can get onto the exam table without major assistance, who reports regular walking, or who maintains balance and coordination immediately registers as higher functioning. That doesn't mean frail patients receive less compassion, but it does mean treatment choices may be adjusted toward risk reduction rather than maximum intervention. Cognitive independence matters just as much. Patients who can clearly explain symptoms, understand instructions, and ask informed questions give doctors confidence that treatment plans will be followed correctly. Confusion, memory gaps, or medication mismanagement raise safety concerns. In those cases, doctors often simplify regimens or avoid complex therapies that require strict adherence. Social independence is another hidden factor. Seniors who live alone successfully, maintain friendships, attend activities, or have reliable family support are seen as lower risk after treatment. Isolation raises red flags for poor follow-up and complications. Doctors may become more cautious if they believe a patient has no one to notice warning signs or help during recovery. Importantly, independence is not all or nothing. Even partial self-management makes a difference.
Using pill organizers, keeping written health records, arranging transport, or participating in physical therapy all demonstrate functional engagement. These signals tell a physician, this patient is actively maintaining capacity. The encouraging truth is that independence can be strengthened at any age through movement, routine, mental activity, and support planning. And when seniors actively protect their independence, doctors notice. It influences not just how they are perceived, but how confidently and assertively they are treated.